Next up, we have Dr. Linda Jaber, who is the OG of our research work. She's one of the first researchers that work with access. So we're excited to have you on here, Linda, and look forward to hearing more about your work.
Thank you, Madiha, for inviting me and also for the introduction. I think there is an example of inequity here. I came after Dr. Hammami, so whatever I do, I think it will not be good enough. But my 10 minutes here will focus on diabetes. This is my area of research, but also we're focusing on diabetes for two reasons. One, the world is in the midst of a diabetes epidemic that keeps growing unchecked. And also the MENA region that we are so interested in is expected to have the second highest increase in diabetes prevalence in the next 10 to 15 years. And in the US itself, diabetes is much more common among racial and ethnic groups and low-income groups. And the second reason why diabetes is so important is that research have shown and established that social determinants of health actually have a great impact on type 2 diabetes. Studies have shown that the risk of diabetes, the risk and severity of diabetes and its complications are very strongly related to ethnicity, economic status, availability of healthy food and living conditions, access to care, education, and so forth. And so diabetes is a public health crisis that will require approaches that actually focus on social determinants of health. And if we're talking MENA region, I think that that's an area we can brainstorm on how to address and talk about. So my early research on and consistent with my training focused on response differences to chronic hypoglycemic agents. However, I was always interested in ethnicity and have developed and tested a diabetes specific pharmaceutical care model that had shown to be effective and resulted in better outcomes in African-American patients with diabetes. But I think the focus of this for today is really on my studies related to diabetes in Arab Americans. Can we move to the next slide, please? Okay, so this slide sort of like, and I believe that's what I was asked for, like an overview of the research I've done in the Arab American community. And I wanted to say here that none of the studies I have done really had focused on social determinants of health. In particular, however, much of the data shed light on several aspects of social determinants of health. My initial work started with a cross-sectional population-based study that aimed to look at the epidemiology of diabetes and pre-diabetes in Arab Americans. And the prevalence rates that were reported from the study were the first reported representative estimates of diabetes and pre-diabetes in Arab Americans. And overall prevalence was 18%. At the time of the study conducted, the prevalence rates in the US was 8%, so it was significantly higher. Undiagnosed diabetes, which is so important, was also so high, bordering around 9 to 10% of the participants. And again, this was cross-section, it was randomly selected, I believe state-of-the-art epidemiology kind of thing. But what I was struck with more than anything else was the high prevalence of pre-diabetes, which is a known risk factor for diabetes in our sample. 30% of men and 17% of women had pre-diabetes, and therefore they were at risk of diabetes. Doing all these studies, we also we were very much aware that conducting research in any minority group is challenging. And therefore, we made concerted effort to explore some of the barriers. And I can talk about this in breakout rooms if you like, and also put strategies to address these barriers when we're doing this research. But I also went on to look at the underlying metabolic defects responsible for the progression to diabetes in Arab American, and was able to document or demonstrate that there are differences in these metabolic defects in different racial groups, including Arab Americans, which would mean that we might have to go for different strategies for diabetes management or diabetes prevention in different populations. We looked at vitamin D insufficiency, and that was very, very common among Arab Americans. And there was a direct relationship between vitamin D insufficiency and insulin resistance leading to diabetes in this group. We examined the utility of A1C testing to identify diabetes and pre-diabetes in Arab Americans, and we were able to demonstrate that the utility of A1C test in Arab Americans reveal high proportion of false negative, and therefore we propose that testing for diabetes and pre-diabetes in Arab Americans rely on other glucose measurements. We looked at quality of diabetes care to those Arab Americans with diabetes, and we looked at several markers for that and compared that to the national standards using the NHANES. And I'll just give a few examples. The A1C targeted goal for patients with diabetes of less than 7% was achieved by only 30% of the population. LDL goal was achieved by about 46%, and the blood pressure goal was achieved by only 16% of population. And all of these numbers were way below the national average. We also looked at utilization of hypoglycemic agents. Arab Americans were more likely to be placed on oral agents compared to the national standards, where there's more use of insulin and the newer agents for diabetes. We looked at aspirin utilization, and that's an antiplatelet that's recommended for significant portion of people with type 2 diabetes. And again, the utilization among Arab Americans was so small, about 23% compared to almost 80% nationwide. So the quality of Arab Americans with diabetes were less likely to have good glycemic control, were less likely to have good blood pressure control compared to the national standards. Then we did a couple studies looking at diabetes self-management. We're all aware that this is an integral part of diabetes management, and we try to identify cultural barriers and cultural facilitators to DSME. And we also examined whether there are differences between patient and provider perspective on cultural impact of the Arabic cultural impact on DSM. And again, we can these are published data, and we can always go back to them. We looked at Ramadan. The community in Dearborn are majority Muslims, and majority will observe Ramadan despite diabetes can be considered an exemption to fasting. And we did a local study looking at practices and complications related to fasting during Ramadan. But we also I was involved in a multinational study that involved Egypt, Jordan, Saudi Arabia, and other countries, and examined the impact of individualized pre-Ramadan education on clinical outcomes. And that was proven that this would really lead to a safer fast in patients with diabetes. Because of the high prevalence of pre-diabetes in this community, I was very much interested in diabetes prevention. And at that time, the diabetes prevention program was published. This was a very huge landmark study showing that diabetes can be prevented. And in preparation for this particular study, which was NIH funded, we looked at barriers and facilitators to adopting diabetes prevention activities, and there were a number of them. For example, poor knowledge, things like that, no time commitment to this, very little knowledge about prevention strategies and how can you accomplish them and all of that. We also looked at perceived risk. And despite that, most people, Arab Americans, can identify that diabetes is a very common disease among community members. However, they downplayed their own future risk of diabetes, which also again relate back to poor knowledge. And we were able to demonstrate that those with high self-reported perceived risk were more willing to adopt and enroll in diabetes prevention activities. Then we did the study, which looked at the feasibility and the effectiveness of culturally specific lifestyle modification model in diabetes prevention. I want to talk a bit about this in a minute. And then at the end of the study, we looked at factors that predicted the response to diabetes prevention. Next slide, please. Okay, so before we start that big study, we did a number of things. One, we did a number of focus groups to explore the cultural norms, the knowledge deficiencies, which was a big problem, to identify barriers and promoters to participation, to examine the participants' preferences for the delivery of the intervention, and also to evaluate the cultural appropriateness of the intervention. Another area we also looked at prior to the study was the degree of silencing or self-disclosure in a mixed gender group. And using computed methods, we were able to demonstrate that men spoke more in mixed groups and with more verbosity than women did. And in men groups, like men alone or men or mixed groups, men spoke more frequently, and the conversation was more dominated by fewer participants than when we had females only. We put together a committee of healthcare providers and also community members, and this committee was charged with modification and cultural adaptation of the planned intervention. And prior to enrolling these patients into the study, they had to complete an educational program. This was based on the health belief models, and the program was designed to identify and modify health beliefs and health behaviors, and to correct misconception and to provide education and correct knowledge deficits about diabetes, which in that education itself really promoted the people to be more willing to enroll in our study. Next slide, please. I'm not gonna talk particularly about the study. There's so many points there, but I wanted to present, and I think that's what Madi had asked me to do, this diabetes prevention model. The key features of this is it was culturally specific. So we took the core curriculum of the diabetes prevention program, and we did not just translate into Arabic. It was revised to be consistent with the Arabic culture. And then we also added session on Ramadan to address issues related to Ramadan itself. Arabs like social interactions, so all the intervention was done in the group session, in the group format. But we gave the participant the option to either join a female only or mixed gender groups. It was family-centered because family play a central role in the Arabic culture. And so we invited wives, we invited husbands, we invited kids to all of our sessions. And that was really, I think this part was really predicted response to our interventions. We use peer mentoring, study participants served as coaches to other participants in their groups, and that also really worked very well. It was all community-based. Everything was done at Access. Even the exercise intervention, especially because it was same-sex kind of intervention, we used Access facilities for that. Delivery, all sessions were facilitated by an Arab American.
I just want to let you know we have to kind of start wrapping up. So.
Yes, and we'll use a number of learning formats. I can skip that. Can you go to the last slide, please? So the thought is, like of all of things I'm doing, I had a principle. It's much more important to know what sort of person this disease has than what sort of disease this person has. Thank you.
Thank you so much.